everyone. Thank you for joining us today for the fourth CGA podcast of the season. My name is Leah Biller, and I'm a medical oncologist at Dana-Farber Cancer Institute. Today, rather than Journal Club, we will be presenting two very important abstracts that were presented at the American Society of Clinical Oncology 2020 annual meeting. First, the Keynote 177 study, pembrolizumab versus chemotherapy for microsatellite instability high, mismatch repair deficient metastatic colorectal cancer, and the oral abstract 1500, targeted therapy based on germline analysis of tumor normal sequencing, MSK impact in a pan-cancer population. I am very lucky today to be joined by two of our esteemed medical oncologists and CGA members, Dr. Michael Hall from Fox Chase Cancer Center and Dr. Zofia Stadler from Memorial Sloan Kettering Cancer Center, who is the first author and presented the oral abstract 1500 at ASCO. Both of these abstracts highlight ways of personalizing the cancer treatment for patients, for those with microsatellite or mismatch repair deficient colon cancers, and for patients with germline alterations that have actionable therapeutic targets. As the field of oncology continues to evolve toward identifying treatment options targeted to the specific biology and genetics of tumors, there may be important practice-changing implications. So, with respect to practice changing, let's first talk about the Stage 3 Keynote 177 study, which was a plenary abstract this year and presented by Dr. Terry Andre. Dr. Hall, could you please start by describing the basics of this trial and the types of patients that were included?
Sure, absolutely. So this was a study that was really designed with the intention of trying to change the standard of care in the treatment of metastatic colorectal cancer, at least in regards to microsatellite high colorectal cancer patients. So we know that microsatellite high colorectal cancer patients represent about 4 to 5% of diagnosed metastatic disease in colorectal cancer. So this was the population that was being accrued and sought out for this study. The design was very simple, and I think that the beauty of the design makes the results even more impactful. So patients who had metastatic disease and were found to be MSI high by immunohistochemistry or the classic PCR-based MSI high were then randomized to either receive pembrolizumab therapy every 3 weeks, or they were randomized to receive the sort of dealer's choice from the treating attending. And there were a number of different choices, all which are appropriate therapies in frontline metastatic colorectal cancer. So FOLFOX plus bevacizumab, FOLFIRI plus bevacizumab. And for those individuals who were KRAS wild type, you could choose FOLFOX plus cetuximab or FOLFIRI plus cetuximab. So it makes it a much more real-world setting that oncologists choose the treatment when patients did land on the usual care arm. But then, of course, all the patients who went on the intervention arm received pembrolizumab. And then basically people were treated, and then they were followed out. And the data that were presented to us, I think the maturity of the data, they had data all the way out to, I believe, at least 24 months when these data were presented.
And can you talk a little bit about the results of the trial?
So the trial was strikingly successful. In these trials, there's a whole bunch of different endpoints that we look at and lots of different initials and letters. But let me just sort of say from the beginning that there were two endpoints that these investigators were looking at. They were a co-primary endpoint. Number one was progression-free survival. And what is progression-free survival? It means the amount of time the patient is treated on this regimen, or they actually have a disease that is clearly growing and then would need to be transitioned over to another regimen. So shrinkage of disease or stable disease is not progression. Progression is actually growth. The other endpoint that was looked at here is overall survival. And I think traditionally in oncology, that's always been sort of the highest bar. It's always great. We feel better when people are progressing slower. We feel better when we have numbers that say disease is being controlled better or disease control rate is higher. But ultimately, of course, what patients want and what we want as doctors is for people to live longer. So overall survival was the second endpoint. And what they reported at the trial, what Dr. Andre reported was the median progression-free survival. And what they found was that the pembrolizumab arm essentially doubled the median progression-free survival in those patients who were randomized to that arm. And the hazard ratio for that result was 0.6, which is very strong. And the p-value was significant, out to 0.0002. So there's no question that pembrolizumab in this population was effective at improving progression-free survival. Now, the overall survival is going to take longer for those data to come out. And perhaps along the way in this questioning, we'll talk about why the overall survival data will be a little harder to interpret because of the crossover in the trial. At least for what they reported here, this was very positive.
Very exciting results indeed. But now, how toxic is pembrolizumab? What did they find in terms of side effects from both standard of care and the pembrolizumab?
Yep. So it is a good question, and I think it's a great question, especially because I do believe among patients who have read about immunotherapies, there's a bit of a misperception that immunotherapies are completely free of any side effects. The good news of this study was that the adverse event rates, so grade 3 toxicities or higher, were certainly lower in the pembrolizumab arm. The rate was, I believe, 22% compared to chemotherapy arm, where the rate was 66%. So people had fewer toxicities, but they did still have toxicities, and some of the more irksome and sometimes difficult to manage immune-related toxicities related to pembrolizumab, such as hepatitis, such as immune-related colitis, thyroiditis, some of the others. These things were seen, and there were people who had these, and there were people who actually had to discontinue therapy because of these. The discontinue rate for the pembrolizumab, I believe, was approximately, I think, 14-15% of people had to discontinue the pembrolizumab because of an adverse event. So even though that's lower than chemotherapy, it certainly is not zero.
You mentioned that patients were able to cross over. Can you tell us a little bit about what that means, and as you had commented on, how that might impact how we interpret the overall survival results when they come out?
Right. So crossover is something that clinicians like Dr. Stadler and me who do clinical trials like, because our patients tend to like it. It tends to be something that the people who design clinical trials do not like. That's because specifically for the overall survival endpoint, what it means is that someone who was randomized to the standard of care arm, the dealer's choice chemotherapy attending who was leading that patient, once the patient progressed, they would be allowed, because of course they were MSI high, that's what got them on the trial, they would be allowed to go over and get pembrolizumab as a secondary treatment. So of course this is good because, ultimately we see on the trial that many of these people responded. So it gives these patients an opportunity to get the drug that may be incredibly beneficial for them. And I think likely we'll see that many of those patients who crossed over benefited. Of course, though, the weakness of that is that you don't then have a clear distinction of people who only got pembrolizumab and look at how long they live versus people who never got pembrolizumab and looking at how long they live. So what crossover does is it diminishes ultimately the differences in overall survival that you're going to see between the chemotherapy arm and the intervention arm, which is here the immunotherapy arm. So in the end, we may see, when we're looking at the overall survival data when they come out, what we'll probably hopefully see is potentially extended overall survival compared to past trials where patients only got chemotherapy. But when we actually look at the comparisons here between the arm that originally got pembro and the arm that started with chemotherapy, we may not see as big of differences because so many people crossed over to the other side.
Great, thank you for explaining that. Now, this trial looked at pembrolizumab. Are there other trials that are looking at different immunotherapy agents?
There are actually a ton of immunotherapies that are PD-1 and PD-L1 directed now, and there are a number, I won't go through all of them, of trials that are using these kinds of agents in the adjuvant setting and the metastatic setting. I'll sort of focus on a couple studies that are using another agent called nivolumab. Nivolumab was one of the earliest immunotherapies to be used in the treatment of MSI-high colon cancer. So there was a trial published by Michael Overman and multiple collaborators a few years ago that looked at nivolumab monotherapy in the metastatic setting, but not frontline. That showed benefit. They also had a companion study that showed that nivolumab plus another CTLA-4 inhibitor called ipilimumab were actually also beneficial, did slightly better in terms of response rate and efficacy with really not a lot of extra toxicity. So those two trials were out there in the metastatic but not frontline setting. There is another trial that is a phase 2 trial that has reported now results a couple times called Checkmate 142. This study randomized, I believe, about 120 people between nivolumab alone and nivolumab plus ipilimumab. What was a little different about this is that the treatments were just given every 6 weeks, and the ipilimumab was given and it was lower dose. So they have found good efficacy on this study as well. This is, of course, not, though, a large randomized phase 3 like this where you compare immunotherapy to the standard of care, which was chemotherapy. So I think the results of that study are also exciting. I suspect we are going to see the use of dual agent immunotherapy as well for patients who have MSI-high cancers. But again, the research is sort of not as advanced or at the same level as we are with pembrolizumab right now because we have a randomized trial that tested against the standard.
So how have these results impacted your practice?
And I think it really has changed the way that we approach that small group of people, that small but I'll say exciting group of people who do have MSI-high. Does, of course, immediately is, and I think many people have already been doing is obviously it's very important from the very beginning of the diagnosis of someone with metastatic colon cancer to know their MSI status. Because if they are MSI high, the first thing you really have to think about is sort of what's the state of their disease, how symptomatic are they? Are they someone who has disease that would be amenable to starting with an immunotherapy like pembrolizumab or potentially in the future nivolumab, ipilimumab, versus starting with chemo? And the way I think about it is really that, fortunately, there will be some of these people who are MSI high who may be perhaps a BRAF mutant, and they may actually have much more aggressive behaving disease. The disease may be growing fast. They may be losing a lot of weight. They may feel terrible. That actually may not be the best patient up front to start with immunotherapy, because immunotherapies, they do take some time to sort of, as I like to say, kick in, for the immune system to really activate and recognize the tumor and get started in terms of shrinking the tumor. And what we actually saw on the 177 study was actually, when you looked at the PFS curves, actually the pembrolizumab curve dipped quickly before the immunotherapy curve. It actually started doing worse at first, and it was about maybe 4 or 5 months where you started to see the immunotherapy curve start to recover and then start to do a lot better than the chemotherapy curve. And that's because there is a group of people who have more aggressive colon cancer who, frankly, are probably always going to need some chemotherapy first to bring their disease under control. Once you get some of that control going, if they are MSI high, then that's probably the best time to put your immunotherapy into the mix. So again, to get back to your original question, I think it's going to help us, or it's going to force us to think harder about when we have MSI high patients, are they a good candidate to potentially start immunotherapy first? I think what this study has shown us is for those people who are good candidates, and I actually have a few of them in my practice now, there are going to be people who it's going to be amazing. They're going to never have to see chemotherapy. They can just get started on immunotherapy, hopefully, knock on wood, not have a major immunotherapy side effect, and potentially, who knows, even be cured by these treatments. And that's obviously remarkable. I'm sure Dr. Stadler would say the same thing when we have been treating these patients with chemotherapy, which is very toxic. Again, I think the other part to think about, and then I think that though we are going to have to be thoughtful again, we have to always remember that of MSI high cancers, some of them are Lynch syndrome related, but many of them are related to methylation of the MLH1 promoter and BRAF positive. These are often much more aggressively behaving tumors. And so even though this study has shown us some great data, I think we're going to still have to be thoughtful about who we're going to start immediately on immunotherapy and who may need a little bit of chemotherapy first to bring the disease or symptoms under control.
Well, thank you so much for that expert commentary on a really exciting abstract, truly practice-changing. Next, we would like to talk to Dr. Stadler about her oral abstract entitled Targeted Therapy Based on Germline Analysis of Tumor Normal Sequencing, MSK Impact, in a pan-cancer population. Dr. Stadler, thank you for joining us today. I was hoping you could start by telling us a little bit about what led to the concept for this project.
Hello. Hi, Dr. Biller. Thank you so much for having me on the podcast today. So the idea behind our project was that we know that over the last 20 or so years, cancer genetics and germline genetics specifically has had a very important implication for the management of our cancer patients. But usually this pertains to the type of surgery that our germline positive patients undergo, such as a bilateral mastectomy in the case of a BRCA positive mutation, or risk reducing measures such as bilateral self-hinge oophorectomy, again for BRCA mutations. And in the long term, for those patients who survive, it has very important implications in terms of appropriate cancer surveillance measures. And then, of course, it has important implications for predictive genetic testing for at-risk relatives. But traditionally, the thought has been that in metastatic or advanced cancer patients, germline genetics has less of a role. Sure, germline testing can identify at-risk relatives of that patient, but otherwise it would have little impact for that patient. However, over the last probably 4 or 5 years, there has been a number of new targeted therapies that have been approved based on germline genetic implications. And what we wanted to assess is the clinical impact of germline findings on targeted cancer treatment, especially in our advanced cancer populations. So the goal of the study was really to assess the clinical utility of identifying germline alterations in cancer susceptibility genes for targeted therapeutic interventions in a pan-cancer patient population.
Could you explain a little bit about how your study was designed and what patients in the pan-cancer population you were looking at?
Absolutely. So our study utilized the MSK Impact assay, which is a parallel tumor normal sequencing platform where patients provide consent to tumor as well as a normal blood sample acquisition. And this impact panel consists of over 400 cancer-related genes with the primary aim of really identifying genomic somatic alterations in the tumor. But the matched tumor normal sequencing utilizes a subtraction method wherein we can also call germline variants. And we can actually report out germline variants for the population of patients who consent to such germline testing. So our study utilized this germline component of MSK Impact, wherein we assessed 88 different cancer susceptibility genes, and we identified patients with likely pathogenic or pathogenic germline alterations in those 88 different cancer predisposition genes. Our study incorporated over 12,000 patients who consented to germline impact from 2015 to 2019. And subsequently, for those patients who tested positive, we reviewed all of their medical records to identify any known therapeutic targets that the patient may have received based on the germline targeted treatment, either in a clinical or in a research setting.
And what did you find in the study?
So what we ended up finding is that about 17.1% of patients had a likely pathogenic or a pathogenic germline mutation overall, including about 11% with high or moderate penetrance cancer predisposition changes. And this was not a big surprise. This was previously published by us in a smaller cohort of patients in JAMA, where again, 17% of 1,000 patients harbor the germline mutation. But what we did then is that we classified these germline findings according to classification method that helped us classify whether a germline finding had therapeutic actionability. And unlike for somatic alterations, where the clinical implications and biological consequences of these genetic alterations are clearly annotated in programs like OncoKB, for example, the classification of germline alterations for therapeutic actionability specifically are really not well categorized. So we used a tier-based system based on one prior publication and partially based on the somatic data, wherein tier 1 alterations were those genes with sufficient evidence of clinical benefit to gain regulatory approval. So this would be like PARP inhibitor in BRCA-associated ovarian cancer, for example. Tier 2 were those where the quality and level of evidence is similar to tier 1, but without regulatory approval. And then tier 3 genes were those with any evidence of clinical benefit for selecting a treatment. And what we identified is that based on how stringent the criteria we used were, 7.1 to 9% of patients harbored a germline mutation with therapeutic actionability. Specifically, then we looked at the number of patients who had advanced cancer and how many of those patients actually received such therapeutic treatment. And what we identified is that overall, we had 593 patients with advanced cancer who had a germline mutation with therapeutic implications. And of those, 44% actually ended up receiving targeted treatment based on the germline alteration. This included about 50% of our BRCA1 and BRCA2 carriers, about 60% of Lynch-positive patients, and 40% of our PELB2 carriers, for example. Specifically, when we looked at BRCA-positive advanced cancer patients, we saw that the PARP inhibitors were given to 88 or almost 90% of ovarian cancer patients. And this, of course, makes sense because the PARP inhibitor in ovarian cancer was first approved in 2015, and that was the earliest approval. It was given to about 54% of our BRCA-positive breast cancer patients. But in the research setting, it was also given to 50% of pancreas and 34% of our prostate BRCA-positive patients. Now, I say in the research setting because we actually ended our study at the end of 2019 prior to the recent FDA approval of PARP inhibitors in pancreas cancer, which was in December 2019, and in prostate cancer, which was just in May of 2020. Suggesting that these patients would not have been eligible for such treatment had it not been for their genetic testing and thus enrollment on a clinical protocol. Other cancers where patients with PARP inhibitors were treated were BRCA-associated bile duct and ampullary tumors, cancer of unknown primary, stomach cancer, bladder cancer, and even a melanoma. Interestingly, we also found that when we looked at other genes such as PELB2, again, about 40% of those patients received treatment, including a number of prostate and pancreas cancer patients. Again, those were on clinical trial protocols. About 20% of our ATM carriers received targeted treatment, again, with a PARP inhibitor, and 37% of our RAD51C and D germline mutation carriers received the targeted treatment with a PARP inhibitor. Most of these were actually ovarian cancer patients. So overall, our study suggests that in addition to all the importance of germline genetics in identifying risk and subsequent future cancer risk and risk reduction, I think it's fair to say that our advanced cancer patients also tremendously benefit from germline testing. The level of benefit is somewhat dependent on what genes we take into account and on the newer studies that are coming out on other targeted therapies that may eventually be FDA approved.
Well, I think it's really telling that even within, the time frame of your study, there have been dramatic changes in how we're using germline information in taking care of our patients. So really exciting. Any other similar studies like this?
Yeah, so I'm glad you asked that. There was a very nice study which is abstract 1501 that was also an oral presentation during the same session by Aaron Cobain and colleagues from University of Michigan. And they actually did quite a similar study. They did tumor molecular profiling via next generation sequencing of about 1,000 cancer patients through exome and transcriptome sequencing. And similar to ours, they also found that the overall pathogenic germline variant rate was about 16%. And of those patients, about 30% of those positive patients harbor germline mutations, either in double-strand DNA repair genes like BRCA1, BRCA2, ATM, etc., or in DNA mismatch repair genes, but which Dr. Hall already referred to as being very important for immunotherapy. So their study was very similar in that it also identified similar rates of targetable germline mutations. They also commented on how some of these patients received the targeted agents and actually benefited from such treatment. So I think it was interesting to see that both of these studies were independent, but really presented in parallel.
And how should we take these results and use it to influence how we're practicing and caring for our patients?
So I think that's a really, really good question. So we know that tumor somatic mutation profiling identifies patients who may be eligible for targeted treatment. But I think that this brings to light the importance of also doing germline assessment, whether that's doing just tumor only assessment where you're calling both tumor or somatic and germline variants, or whether you're doing it in a parallel way like we do at MSK. I think it's important to recognize that we may be missing some patients and some potential therapy options for these patients if we don't do both somatic as well as germline assessment in our advanced cancer patients. So I think we need to integrate these two things a little bit better than we do today. Not to mention that I think there's a lack of classification system that's clearly there in somatic mutation profiling with things like OncoKB. And I think better harmonization of the therapeutic actionability of these germline mutations is certainly needed.
I fully agree. I really enjoyed both Dr. Stadler's and the University of Michigan, Dr. Cobain's abstracts. I think these are super important because I think, there still is this sort of split out there in oncology where a lot of our onc-doc colleagues who are less interested in the germline than Dr. Stadler and me, they're very focused on tumor testing as simply a mechanism to get to a therapy. But I think what their abstracts help us elucidate is really, as we've all known for a long time, the germline and the tumor profile, they are intimately related and crosstalk between them. And so I think this really helps elucidate that point. But I echo what Dr. Stadler said as well, that what we really also need is again, better, she put it very well, harmonization between when we find these targets, what tumor types are they going to work. For instance, we know sort of BRAF is very targetable in melanoma, but is sort of less targetable in colon. Now that we have targets, we don't want to keep practicing oncology like we used to, which is just sort of volleying drugs all over the place. We really want to know that we're using a target well and that it's going to actually help someone. So I think this is obviously a great step in that direction. And as more studies are identifying targets, then we'll have more studies where we're actually giving people these drugs to hit those targets, like the MATCH and TAPER and other studies and the work that's being done in Memorial. So it's all super exciting. We live in a great age of oncology, and studies like this have really helped push the envelope.
And with that, I would like to thank both of our discussants, Dr. Howell and Dr. Stadler, for their very thoughtful commentary and sharing their experience with me and all of our listeners today. And to the listeners, thank you for joining us on this ASCO 2020 version of the CGA podcast series. We hope you enjoyed it, and please stay tuned for upcoming Journal Club podcasts where we highlight other important updates in the field and literature.